Hello everyone, today we'll be discussing Wilms tumor, which is also known as nephroblastoma. So Wilms tumor or nephroblastoma is the most common pediatric renal cancer, the most common pediatric abdominal cancer, and the fourth most common pediatric cancer overall. Wilms tumor is typically found in children younger than 5 years. Etiology: the cause of Wilms tumor is not precisely known, but it is believed to be due to genetic alterations that deal with the normal embryological development of the genitourinary tract. Some of the genetic markers that have been associated with Wilms tumor include WT1, CTNNB1, and WTX gene alterations that have been found in about one-third of all Wilms tumors. Histopathology: so grossly Wilms tumor are usually well circumscribed and have a pseudocapsule. Histologically, Wilms tumor is divided into favorable and unfavorable histologies. So favorable histology: 90% of Wilms tumor will demonstrate favorable histology, which generally has a better prognosis. So when you look at the diagram on the side, that's what we're describing. So the classical histological features of a favorable Wilms tumor includes a triphasic pattern of a blastema, epithelial, and stromal tissues. Then unfavorable histology. So Wilms tumors with unfavorable histology will demonstrate much higher degrees of anaplasia and are associated with a relatively poorer prognosis and survival. So anaplasia is histologically defined as hyperchromatic pleomorphic nuclei that are 3 times larger than adjacent cells and have abnormal mitotic figures. Anaplasia is associated with a poor response to treatment. So history and physical examination. So Wilms tumor usually presents as an asymptomatic abdominal mass in the majority of children. The mother may have discovered the mass during bathing and the infant. Other features include abdominal pain, gross hematuria, UTIs, varicocele, hypertension or hypotension. So of notice, up to one-third of Wilms patients will demonstrate hypertension, which normalizes after nephrectomy. Then fever, anemia. If the patient has lung metastasis, dyspnea or tachypnea may occur. Abdominal pain is the most common initial presenting symptom in about 34 to 40%, followed by hypertension in 25% and hematuria about 12 to 25%. So evaluation of a patient with Wilms tumor: the usual labs are not specific for Wilms tumor, but they need to be ordered to look for other pathologies. So routine blood work includes complete blood count to look for anemia, biochemistry profile, renal profile, urinalysis, coagulation studies, cytogenetic studies to look for 1p and 16q deletion because these are associated with Wilms tumor. Imaging studies that are utilized include the following: renal ultrasonography, that is as an initial study; chest x-ray to look for lung metastasis; abdominal and chest CT with sedation. Abdominal MRI is an optional study, but then we'll discuss more about the abdominal MRI in the coming slides. So treatment of Wilms tumor is usually nephrectomy that is followed by systemic chemotherapy. However, some protocols initiate chemotherapy first and do the nephrectomy later. The opposite kidney may be explored to ensure that cancer has not spread, although this is unnecessary for low-stage tumors with favorable histology if imaging is negative. Then lymph nodes around the aorta are sampled for staging and to improve survival. Staging: so stage 1 indicates that the tumor was completely contained within the kidney without any breaks or spillage outside the renal capsule and no vascular invasion. This stage accounts for 40 to 45% of all Wilms tumors. Then stage 2 is a tumor that has grown outside the kidney to some degree, such as into the surrounding fatty tissue. Usually the tumor would be completely removable by surgery and regional lymph nodes are negative. About 20% of all Wilms tumors are at this stage. Then stage 3 comprises about 20 to 25% of all Wilms tumors and indicates a tumor which could not be completely removed surgically. Stage 4 tumors are those that have spread through the vascular system to distant organs such as the lungs, liver, brain or bones, or to distant lymph nodes. These account for about 10% of all Wilms tumors. Then stage 5 are those cases where both kidneys are involved with tumor at the time of initial diagnosis. Then about 5% of all Wilms tumors are at stage 5. So this is basically a summary of the staging. Then prognosis. So prognosis varies by tumor stage and histology. So favorable histology has survival rates of 99 to 86%, while unfavorable histology survival ranges from 84 to 38%, that is depending on the staging. End-stage renal failure occurs in about 1% of patients, usually due to metachronous bilateral tumors. Then females with Wilms tumor and iridia WAGR syndrome may develop streaked ovaries and are at an increased risk for developing gonadoblastoma. A poorer prognosis is associated with the following characteristics, which is anaplastic histology in stage 2 to 4, diffuse anaplasia is worse than focal, loss of heterozygosity at chromosomes 1p, 1q, 11p15, and 16q, or presence of TP53. Higher stage, most epithelial predominant tumors are stage 1, most blastema predominant tumors are stage 3 and 4. Age older than 2 years, higher positive lymph node density, larger tumor size. Even small tumor foci can be associated with a poorer prognosis due to resistance to chemotherapy. That's all about Wilms tumor. Thank you.